we're a little behind schedule, so we'll try to see if we can speed things up. Orders from the boss here. So welcome to the Coronary Surgery Video Masterclass 2. We have a number of world experts who will teach us how to do innovative approaches to take care of coronary artery occlusive disease via surgical technique.
So reconstructions in total arterial vascularization is the basis. And John Puskas is the most appropriate person to speak about them.
There we go. Super. I've often described coronary bypass surgery as a two-step operation: harvest the conduits and deploy the conduits. But in fairness, it is often a three-step operation: harvest the conduits, build the composite conduits, and then deploy the conduits. So I'm going to talk on this in this talk about how I build my three favorite composite conduits: the I, the T, and the baby Y, which is a phrase coined by Jim Tatulis. My disclosures. Briefly, why do we do multi-arterial grafting? It's because it makes patients live longer. These are the data from the Cleveland Clinic through 20 years showing double mammary beats single mammary for long-term survival. And more recently, a 1 million paper study from the STS database with very careful statistical analyses and compensation for bias, demonstrating that risk-adjusted survival with multi-arterial grafting, or MAG, beats single arterial grafting through 10 years of follow-up with a highly significant p-value. And this was demonstrated in whether it was a propensity match set of pairs or with various sensitivity analyses. And interestingly, it was in a time-segmented analysis. Not surprisingly, the benefit really began to appear at about 5 years and widened over subsequent follow-up. And it was seen in all patient groups: left main, 2 and 3 vessel disease, good ejection fraction, low ejection fraction, urgent and elective, and on and off pump. The benefit was greatest, as one might expect, in the youngest patients. They have the longest to live. Only patients who were massively obese with a BMI greater than 40 did not benefit from double arterial grafting or multi-arterial grafting. And despite all this data, you can see that in the United States STS database, only about 14% of patients have more than a single arterial conduit, and they're about evenly split between double mammary and radial artery, although perhaps a few more radial artery grafts being the second conduit rather than right internal thoracic arteries. So again, the 3 steps of my favorite operation, all arterial, no aortic touch OPCAB, are harvest atraumatically, as Rich Vitale brilliantly demonstrated today, build composite conduits, and then deploy them. So here's how we harvest the mammary arteries. You've seen this harmonic scalpel demonstrated by previous speakers, and I think it's important, regardless of which tool you use, that the arterial conduits are harvested atraumatically. We divide the branches with the harmonic itself as far away from the trunk of the mammary artery as we can get in order to minimize that crucial injury or potential for injury at the branch points that Rich Vitale emphasized. We skeletonize because we know that it preserves retrosternal microperfusion, oxygen saturation, and blood flow, and we presume that this will mitigate against the risk of deep sternal wound infection, which I believe is the fundamental reason why so few double mammary grafts are provided to patients. But there is another way to mitigate against this risk, and I'm just going to ask you all to go home, and if you don't do anything different after this meeting than you did before, except this, it'll make your trip to London worthwhile, and that is use vancomycin paste in the sternal bone marrow at the beginning of the operation and again at the end of the operation before you close. It limits bleeding, it prevents sternal wound infection, and it does not cause any problem in terms of excessive systemic absorption of the vancomycin. In fact, it's a Class 1 recommendation from the AATS Expert Consensus Review. Okay, so strategies for anaortic UPCAB basically hinge on bilateral ITA inflow and RITA, or radial artery composite outflows, the I and the T and the baby Y. And we can use them in multiple ways. First, we have to build an I graft. We spatulate the anastomosis and we put it together in a very, very standardized fashion. This anastomosis is constructed exactly the same way every time. It's up on the drapes, every stitch is visualized. The surgeon and assistant know exactly how it's going to happen. And this is actually the first anastomosis that I let our residents do, because if they mess it up, I can cut it out and do it again. This is a great training tool. It's up on the drapes, well visualized, well illuminated, and then you can look at it, inspect it, and test it for patency and for hemostasis. I never use the ITA, the right ITA, to bypass the PDA as an in situ graft without elongating it. Because even if you pull it down here and think it's going to reach, it's actually a little too tight. And I think that's a major contributor to lower patency rates with ITAs. So we build this I composite conduit to easily reach even over here to the posterior left ventricular branch of the right coronary artery. Now we also build T grafts. We put radial arteries off the side of the lita. We do that also up on the drapes. Before we do any distals, we build the composite conduits. We do it with a well-illuminated field, well visualized, no motion, standardized suture technique. The surgeon and assistant know exactly where each stitch is going to go. Each stitch sees the intima of the donor and recipient vessel. There are no blind stitches. And we ascertain that we have perfect patency and good hemostasis before we proceed with the distal grafting. So here's a intraoperative video of REMA used as a Y graft. So you can take double mammaries and actually use the right off the left or vice versa. And that's basically a different kind of a T graft. You're just using a Rita off the Lita rather than a radial. The size match, of course, is perfect. The thickness of the walls is identical. So this is actually a very natural and beautiful T composite conduit, which can have really a beautiful configuration and very reliable flow. We test the flow in both limbs of this graft before we use it. We think it should have a knee shot. The blood pressure, the flow with a mean arterial pressure of 80 should hit the patient's knee. We can do this with a radial as well. Here's a skeletonized lita. We're identifying the target on the LAD. That's going to be our distal anastomosis. We see the ramus intermedius, or first marginal target there, and we identify the spot where we're going to have our radial artery come off it just inside the pericardial reflection. And then, having measured carefully, we build our anastomosis, again on drapes, immobilized, well visualized, a set piece. This is something you can practice over and over again and literally do it perfectly 100 times or even 1,000 times in a row. This is how we build the conduits for my favorite operation, which is this. I think is probably the single procedure we do most commonly. It's especially helpful for patients with a calcified ascending aorta. It's a Rita extended with a radial to reach the back wall of the heart, the PDA, and sometimes the left ventricular branch. It's a Lita to the LAD with a radial off it to the anterolateral wall or lateral wall. We liked it so much that David and I put on the front cover of our book. This is a variation on that theme, Lita LAD, a radial T graft to the diagonal, the Rita I graft through the transverse sinus to the obtuse marginal. And when we do this, of course, we have to build the grafts first, then we have to pass this Rita through the transverse sinus, which we do very carefully. We want not to twist it. We don't want to have excessive traction on it. There it is there, ready to go. In this particular case, we also put a clip on the appendage for this patient who had a history of AFib but was not in AFib at the time of surgery. And then we construct the Rita extended graft to the obtuse marginal, just as we would do with any vein or radial from the aorta. We document the patency. Then we go to the anterior wall and put that radial side limb to the diagonal and the Lita to the LAD. We test the flow in those grafts as well before finishing the operation. Now here's a sequential Lita to the diagonal LAD with a radial off it to the OM. And this patient also had a clip, but you can see that this is another alternative for all arterial grafting. The baby Y configuration, this is a phrase coined by Jim Tatoulis, the famous radial artery aficionado from Melbourne, Australia. There you can see the radial this is the LITA to the LAD. Here's the radial coming off it, with a short side limb of radial going to a ramus intermedius and the longer side limb of radial going to the first marginal. So this is the so-called baby Y. You might call this a pie graft if you were from Greece, but Jim called it a Y graft. It's actually a T. We sometimes call it the F graft. It looks a bit like an F, but then people think we're swearing in the operating room, and we'd never do that. A K graft is a technique that I learned from Junjiro Kobayashi. So that's one of the reasons I call it a K graft, but actually it looks a bit like a K as well. And this is the radial side to side to the LITA, and the one short limb to the diagonal of the longer limb going around the back, in this case to the distal portion of the middle obtuse marginal coronary artery. And that's what that looks like in a different case. And schematically, we can get 4 or 5 grafts with a sort of a technique. So this is a video tutorial of our technique. It's available online. One of our previous fellows did a lot of work editing this down. I encourage you to go there and have a look at his very nice work. And thank you all for being here today.
So no better person to kick us off at the Masterclass than the master himself. Our next speaker will tell us his experience in 3,000 all-arterial op-cap grafts with the pie graft. Dr. Prapas?
Thank you for the invitation. What I have to do here. Thank you. The P-circuit graft philosophy. In 2001, in our center, we started a program of an aortic op-cap that allowed us not to touch the ascending aorta during the last 15 years. Why philosophy rather than technique? Because in this way, we follow the natural way to perform an additional circuit as in all organs and extremities. An aortic op-cap is more difficult technique, but is significantly superior to all the other techniques. Look at the neurological complications in this study in very high in risk for neurological complications patients, how low is the incidence of stroke in op-cap. Also, how low is the delirium and cognitive dysfunction. This is the only technique which allow us to perform an aortic surgery in cases with porcelain aorta. Pedicle eaters are the blood sources. Some examples, John described all of them. The philosophy about pig graft is that sometimes the patient is not stable, and therefore doing a sequential grafting from diagonal to LAD is dangerous. In other cases, there are some intramuscular branches. In these cases, we can't do sequential grafting or lateral wall. Some videos. This is the small distal mammary to do LAD, diagonal, and at the end, the obtuse marginal. And here is the Y graft. We prefer to cut side branch to avoid any dissections. And we're doing Y graft when we have go laterally, and T graft when we have to go to intermediate and then to obtuse marginal. This is known. Then end-to-end anastomosis to the obtuse marginal. In this case, we connected the left system to the right system. In next video, also, we are using this lambda, Greek lambda graft. Half of the mammary is going as a T-graft to diagonal or intermediate and obtuse marginal, and the other one is connected to the RPD and then connected to the lima. In order to do these configurations, we know that competitive flow is in place, and therefore we follow that Huang stated that the stenosis of the right system, the RPD, must be more than 92%. In this case, in the cases in which the PDA has not so huge stenosis, we are doing double inflow surgery. Like in this case, it's a redo case. Videos are a little bit old. Sequential anastomosis with rima to diagonal and then to LAD. Now, we connect the radial artery to the proximal 1/3 of the pedicle rima, and we're doing the anastomosis on the PDA, and at the end we separate the lateral wall. The patient is stable at this time, having 3 anastomosis done, and we are doing the last one. We had some late postoperative findings in patients in which we did not use the radial as an extension, but just saphenous vein graft. And surprisingly, we found that after many years, this piece of saphenous vein graft was fresh without any arteriosclerosis. We started seeing the bibliography, and we found that everything is the balance between shear stress and nitric oxide, the NO. The shear stress is the mechanical force that drives the adaptation of vessel size to changes in flow and influences the resistance of the graft to atherosclerotic processes. T, blood flow to reduce. The shear stress, when is equal or higher than 10 dynes, plays a protective role, and if is lower than 10 dynes, induces atherogenic and thrombogenic factors. The balance. Endothelial cells regulate vascular tone through a balance between the production of vasodilators, such as NO, and vasoconstrictions, such as endothelin-1, to maintain constant shear stress according blood flow. If blood flow increase, the radius increase. NO high, endothelin low, and the opposite. Look at this, the shear stress in 40 liters and 34 SVGs. After 5 years, the saphenous vein graft on the aorta. You can see here that the shear stress stay low. That is the conclusion. Saphenous vein graft anastomoses to the aorta maintains low shear stress and acquires an atherogenic profile. We know, all of us, that saphenous vein graft on aorta becomes atheromatosus. But look here by Huang, Lita SVG Y graft, shear stress evaluation. After 1 year, 21 from 4.3, and the diameter is lowering. That means something arterialization of the vein graft. These findings open the door to the use of saphenous vein graft in our practice, doing an aortic CAB. And using all the cases in which we included vein graft after 20 years, 10 years, the last 10 years, we found that there is an advantage using the vein graft on ETA. From the aorta, 50%, from the Rita, 81%. That has an impact on survival as well, 56 to 73. Also, we have done computational fluid dynamics analysis, and you can see here how low is the pressure inside the part of the saphenous vein graft and how high is the shear stress. In my opinion, the major physiological advantage of an aortic CABG is that graft and coronary arteries are supplied with blood from the ETAs. The ETA are drug-eluting grafts and release NO into the coronary circulation, increasing its resistance. Here is the concentration of nitrite, a stable metabolite of nitric oxide, in the anterior endoventricular vein before and after Lita anastomosis. How high it becomes like the free Lita flow, and you can see the supply of vein nitrite. After that, we can understand why the coronary arteries, when receive NO from the Lita, show no or little progression of the atherosclerotic disease. Another study. This is the number of aortic cases we have done until last week, but I'm going to present the cases we have studied. On 2016, we presented 3,000 patients, 0.0% rate of stroke. In 20 years, that was the material, single flow or double flow, the graphs we have used, very low percentage of complications, 0.9 death, stroke 0.4, MA and PTCA, and the long-term survival after 20 years. This is the Cox proportional hazard, and this is the stepwise logistic regression, age, emergency, ejection fraction, and peripheral vascular disease, some important. In conclusions, an aortic CAB is a complex procedure that requires specific training as part of a surgical institutional program. Results are great, neurological complications are low, and the incidence of main adverse events is limited. The use of saphenous vein graft from one or both ETAs provides a long and flexible conduit for a complete myocardial vascularization. In my opinion, this is the revival of use the saphenous vein graft in a better way. Here are two pictures from the event we organized last May in Greece, honoring the 7 coronary surgeons of 90s. We named them 7 wise men, and another 7 persons, including many persons in the audience. We described the today environment. Thank you very much.
Very enviable results. Thank you very much for your presentation. Our next speaker will be Mark Ruel, who will teach us how to do sequential distal anastomosis. Professor, how are you?
Good afternoon. Thank you very much, Dr. Proskus, Dr. Taggart, Gianluca, for inviting me. This is going to be a little bit of a simple talk, very technical. Maybe I'll go back before I say. I'm not a huge sequential grafter, I'll be honest. I'll do it once or twice a week, more now than I used to. I've been chair of my division since I was maybe 41 or so. And I've had to go back on Saturdays and Sundays for cabbages, low-risk cabbage, that didn't work because of the sequential anastomosis. So I'm a little bit jaded with them, and it took me time to, quote-unquote, share my LITA, if you will. I think some of us believe that. I'm sure I'm not alone. I'm a bit of an independent multi-arterial graft type of person. There's obviously advantages. So I'm going to show you kind of a lowest denominator way that I do it, which I think prevents trouble. And it's basically one video and then one recap slide. That's it, 2 slides. So hopefully it will gain a little bit of time. So this is a 36-year-old man, obese gentleman who had I believe, a RITA to the OM1 attached, and a LITA to a diagonal and LAD, and nothing skeletonized. It's basically, I know many of us don't like to skeletonize every single case, and hopefully this is something that compels you. So we're going to start. I usually start with a lateral wall. I find it's, if the patient tolerates it, you have a great anesthesia team. I prefer to start there for technical reasons, not physiologic reasons. But when you really have an op-cab as a routine on everybody, I find it works better. It takes away and you finish with the LED. Again, obviously, if someone's a left main or poor LV or ischemia, you start always with the LED and early in your experience. So this is just an end to side anastomosis. This is the RITA pedicled to the OM1. So typically I like to, those who've trained with me said I like to keep it 30 to 50% of a wider opening on the conduit than on the coronary artery. So very simple here. Basically I start, if you will, kind of at 4 o'clock, then do 5 o'clock, 6 o'clock, go counterclockwise, 7 o'clock, and then bring it down for 4 bites. And I find 4 is better than 5 because you can actually roll the suture more easily. It tells you a lot of things when you have shunts, when you have two sutures that may get tangled. So very, very simple end to side, kind of like you probably all do it. Again, you know, if you don't see it, you don't sew it, and you just finish. Now, a few things here. Always keep the shunt in, flush before with the shunt in there. So if there's debris or air, it doesn't go in. The shunt's preventing that from happening. Keep a little bit of looseness, and then remove, basically open both and always tie under dual arterial pressure, if you will, which is what I'm doing here. So no rocket science there, just a case like you would do all the time. Then here I'm just doing my posterior pericardiectomy as after the circumflex graft, as Dr. Lau was showing at the previous session. I do this. I find this especially useful on minimal invasive bypass surgery because it can send patients home on post-op day 2. Then check the flow as close to the distal anastomosis as possible. That's a good principle to follow as well. If you're too close to the aorta, it's somewhat unreliable. Okay, now. What I like to do then is, now we're going to do a sequential pedicled LITA to the LED and to the diagonal. So I like to scratch before, because sometimes if you don't scratch, if you don't just mark, you may have surprises. It's nice to really look that, yeah, this is going to be a viable side. So I just scratched the LED, now I'm scratching the diagonal. So you don't find that there's a plaque and actually, guess what, I don't want to go there. So I think this is a more complete step than just putting some methylene blue on there, or some ink. And then really the best way to make sure this is foolproof, in my opinion, is you make a mock. What is the mock? It's basically you take a 5-0 and you put it on the epicardium right next to you where you're going to graft, and you exaggerate the distance a little bit. You make it a little bit more lateral, a little bit further, and you do the same thing with your diagonal. And the beauty of the mock, not only is it a perfect distance measure is that you can bring down the heart. So all these measurements that happen when you have the starfish on or you have your leader stitches on is not necessarily the same as when the heart's going to be down. So see, basically I took everything and now there's no sponge behind the heart and I can see how this is all going to lie. So then I go back to my 15 blade, cut the mock. It takes a little bit more time, but then you're sure that you're not going to get a call about ST elevation at 3 in the morning, in my opinion, if you do it this way. You've scratched, you've mocked, now the only thing can go wrong is your technique. So the next thing you can see here, there's 2 hair clips there. It's just enough to fill the lita, but not too much. And then I open it for my side-to-side anastomosis. So whichever way you want to do this is fine. Now I would say the 30 to 50% exaggeration I was talking about at an end to side, you don't want to do that in a side to side. You want to be about 10 to 25%. If you exaggerate too much the over-sizing of your conduit versus your target, you may end up with a little bit of a too much spatulation, if you will. So how I do it, I do it then 4 o'clock, 5 o'clock, 6 o'clock, 7 o'clock, then I bring it down, which is basically what you see here. And then I do a couple of more stitches. I'll do 5 o'clock, 4 o'clock, 4 and 3, and then I finish at 3 o'clock, and then I come back with the other one. So again, you don't want to be suturing away from you. And I do a Paris-style technique, if you will. I just learned from a French fellow recently that this is how they do it in Paris, basically out to in, so going outside from inside on the coronary and then in to out on the target. Again, if the artery is very calcified, it's not very good to do that. But remember, you've scratched before and you've gone to see it and you picked your exact spot. You did more than merely marking with ink. And then the beauty with this is that you end up in front of you. And the one last caveat is that don't pull your last 4 or 5 sutures. Don't pull them at all. Flush with your stent and basically just make sure that you remove your stent when everything is very loose. There's nothing more frustrating than you've done a beautiful side to side, but the stent's coming out and you've actually damaged what you just did. And trust me, that can happen. I've had it, unfortunately, many times. Maybe it's just me, but it can happen. So now we're done with this. Measure your flows, make sure you're happy, and then go on to doing your enter side and Bob's your uncle, as we like to say. It becomes a very easy thing to do. So I'm just going to move forward a little bit. We're almost done on the video. So again here, we flush before and then you tie under full pressure. You just pull enough that when you have dual arterial pressure from your conduit and your coronary artery, just enough so you don't bleed. You don't want too much. You can actually, even though you're using 12, 14 stitches around, you can still stenose. I think we've all done it if you pull too hard. You just want to be enough. And then you check your flows. And then the last point is very important. You bring down the heart, and then you really obsess about this whole thing lying down. What's going to get you or get your graft is not a stitch. It's going to be the lie of it, in my opinion. So you really have to obsess, open the pericardium, take away the fat, deflate the lungs, reinflate them, bring the sternum together, and obsess that you're not going to get a call in 12 hours because there's ST elevation on this patient. So just to recap, this is my last slide. Any conduit's fine, vein, you can skeletonize or not. It doesn't really matter. Consider doing a mock and scratching your targets. To me, this is more complete than merely putting ink on it. End to side, 30-50% larger opening than target, but side to side, don't exaggerate as much. Stay 10 to 25%, in my opinion. You do the side to side first. I was mentioning the 4 counterclockwise bite, 4, 5, 6, 7 o'clock. Then you bring it down. Then you do 2 more bites with that, and then you come back with the other strand in Paris style, which basically means out to in on the coronary and in to out on the conduit. You leave your suture loose towards the end. You flush your graft with the shunt still in. Then you remove the shunt and you tie under full dual arterial pressure. Just enough so that you don't bleed, but not too much. And finally, you check all flows and you remain obsessed. This is the time, if there's anything wrong, it's the time to fix it, and not 6 hours later. And I tell the fellows know who work with me, I really believe, I'm so obsessed about closure. I'm scared of closing sternotomies. This is one of the things I trust them with. I always tell them, you lose more grafts by closing than by building grafts. And I really believe that. If the lung or a piece of fat or something is not in the right spot, these poor little grafts have no wall tension to them. This is not the ascending aorta. A surge cell can kink them. So you have to be very, very careful. And even when you take out your sponge after putting the wires, that can be enough to kink a graft and cause a graft that doesn't work. Thank you very much.
Thank you, Dr. Ruil. Now, Dr. Jill Bolotin is going to describe how to do complete clampless proximal anastomosis, and close heartstring viola.
Okay, this is I'm going to talk, my name is Gil Bolotin, cardiac surgeon. I will talk about clampless proximal anastomosis devices. This is my disclosure, it's important. I'm going to talk about three devices. One of them is VGS, and I'm advisor for this company. So first of all, the need. The unmet need is for us, all of us, to reduce neurological complications, and especially for this presentation, the one that's caused by side biting clamp. At the moment, there are three available devices in the market: the heartstring, enclose, and the viola. The heartstring is, I have actually with the heartstring many years of experience. I think it is a good technology that gets the job done. However, over the years, I have found some limitation, particularly the quality of the sealing, which require, for me at least, a continuous use of blower. This may lead to some air embolic into the brain. The sealing with heartstring is actually worst when there is a diseased aorta calcification. I think it's because the limited flexibility of the cap of the heartstring. Moreover, I believe that the real problem with the heartstring is the punch. I think the punch is a bit aggressive, cause a mechanical bump on the aorta, which can lead for a release of debris from the ascending aorta. This is the heartstring. With the enclosed, I have much less experience, but lately we use it in my department because of difficulties to get the heartstring. Generally, I think it's a good technology. However, the limitation in this case are a bit bulky and require at least 2 holes in the ascending aorta. Sometimes it can be a limitation in diseased ascending aorta. So the viola, the new kid in the block, was designed to overcome those limitations, and generally it consists of main 2 elements: the sealing element, the cap sealing element. It's like an umbrella, go in and out in this tiny sheet, and an integrated punch with a plastic handle. So the main part is this umbrella that go in and out to this tiny sheet, and it's actually quite flexible and quite soft, so it's doing a very good job in sealing the ascending aorta while stitching. This is a short video how we do it. First of all, you flush the device in a heparinized saline. Make sure that it's going in and out, intact. Then you choose the right place. I will hold it for a moment. You choose the right spot you prefer to do the anastomosis, and then take a needle and just do a small hole. It can be 14, 15, 17 gauge needle. Since I do most of the cases on pump, in a lot of cases, I'm just doing my proximal antegrade hole. Once you are there, you just put the sheet with the umbrella inside into the aorta, release it inside, pull it very gently, very, very gently, and now you are done. You take the punch out, connect it to the plastic handle, and do the punch. It's very important to notice that the punching, first of all, is very gentle, and it's protected by the cap already, so there is no dangers at that critical part. And now it's like in any other proximal anastomosic device, you have to do your proximal anastomosis. The only, and it's usually very nice and very dry, the only thing you have to make sure is not to hit the cap of the viola inside. I found it easy. And we generally use a special needle, I will discuss it a bit later. Then you finish, you leave 2 stitches loose, take it out, tie, and you're done. The viola can be used again and again on the same patient, up to 4 times. I did many cases of 2 anastomosis, one the vein and one the radial artery. So this is the real video from the human. I did many cases. This, I think, a video from the States. So first, flushing the device with heparin saline, checking the system. It's very intuitive, not science fiction. Then doing a hole in the aorta in the place you want, sliding the device inside, open the sheet in the aorta and pull it up. Connecting the cutter to the plastic handle, go inside the aorta, over the wire, of course, with the sheet protected, and take the piece of aorta out. And now we are done, ready to do the anastomosis. We pull it out. Some people connect it like this. I usually don't connect it. I just use the weight of the grip for really gentle pull-up, usually just in mean of direction, and very, very gentle pull-out, have a good hemostasis. And now the stitching, I think you can appreciate that it's actually not bleeding, like in most cases. And if it's bleed, you just have to find the right spot, again, with a gentle needle, with a gentle pulling. Again, the only 2 tricks for this device. First of all, not to hit the cap inside, and then this is why I use, as recommended, the curved needle that toward the tip it's more curved, and it's very easy to do it without hitting the viola. Actually, if you just take care, it's quite easy. And the other issue with the current device is taking it out. Otherwise, it's very simple. So I pull it a bit inside, closed. Once we finish, we leave, as I said, 2 loose stitches, close it and take it out. In my early learning curve, sometimes it was stuck with the stitches. Now I do it without any problem, but I know that the next generation of the viola will have a nice trick to solve this problem. If I compare all the 3, again, it's my biased experience, but I think the viola has the best sealing, and this is why we rarely or almost not using the blower for doing the anastomosis. And I really like the punch that is integrated to the system, and it's very safe and done under protection of the cap. So in summary, the generally, clampless proximal anastomosic devices are essential for reducing neurological complication, reducing the need for long cross-clamp time, or even the need for using a side-biting clamp. Viola, in my experience, is very simple to use, support multiple anastomosis, and ensure excellent hemostasis. Thank you very much.
Thank you so much, sir. Our last presentation of the session will be by Dr. Ki-Bong Kim, who will discuss saphenous vein graft conduits in the Y and I connection using arterial grafts as inflow, the evidence and rationale.
Good afternoon, Mr. Chairman. I have nothing to disclose. Revascularization using composite graft based on in situ ITA has advantages of efficient bypass conduit utilization and avoiding aortic manipulation. Revascularization using vein as a composite graft is a hybrid arteriovenous graftings having biologic and functional characteristics of the best and the worst conduit used for CBJ. This is a video presentation for constructing Y composite graft using vein as a vein. After localization of Y anastomos site, gripping the proximal ITA using an atraumatic bulldog clamp, arteriotomy using beaver knife, and extension of arteriotomy with IMA scissors made. After spatulation of the distal end of the reverse saphenous vein, continuous suturing using aidopropyl started. After beveling of the spatulated vein to fit into the shape of arteriotomy, suturing is continuous. Beveling the other part of spatulated saphenous vein to fit into the shape of arteriotomy. We use the continuous suturing using aidopropyl. After releasing the bulldog clamp, we check the bleeding. When the ITA is short for target vessel, the ITA can be extended by using I graft. The construction of I graft can be made by end-to-end, end-to-side, or side-to-end anastomosis. In the end-to-end anastomosis, a shorter vein segment is needed. However, it is a little difficult to do because of the distal part of lita is sometimes friable. In end-to-side or side-to-end anastomosis, it is easy to do. However, a shorter or longer saphenous vein segment is needed. There are advantages of saphenous vein composite graft based on in situ ITA over the aortocoronary bypass graft. First, vein conduit is exposed to less circulatory stress than the aortocoronary graft because diastolic and mean pressure of ITA was significantly lower than in the ascending aorta. Second, the saphenous vein is continuously exposed to endocellular protective substances such as nitric oxide released from ITA. And the third, length of the saphenous vein is shorter than the aortocoronary vein graft. The saphenous vein from a lower or upper leg having fewer number of valves is sufficient for complete revascularization in most patients with multivessel disease. However, revascularization using vein composite graft have not been widely used because there are concerns when using the vein as a composite graft. In this paper published by Mario, included 25 patients who received vein composite graft and look at the patency at 2.5 years after surgery. The ITA overall patency rate was 88%, and ITA perfect patency was only 72% at 2.5 years. And the authors have abandoned the use of vein composite graft because of the lower patency of ITA. However, when you look at the data, patency rate of vein was 96% at 2.5 years. It was excellent. And all the ITA malfunctions happened in patients whose ITA was used to revascularize the LAD with moderate stenosis. And there are concerns about hemodynamic characteristics of vein composite graft. In this study, which included 23 patients who received vein composite graft, examined by transit time flow meter intraoperatively. The data showed presence of vein graft did not alter physiological blood flow dynamics in distal part of the left ITA. This another study examined the FFR in patients who received vein composite graft 6 months after surgery. They compared the patients who received the ITA, RITA, and versus saphenous vein graft, and their data showed composite graft allowed similar and adequate deposition of the left coronary system and showed even distribution of flow in both distal branches. In addition, there's a valve in the vein, 2 to 9 valves commonly located. And as you know, more accelerated atherosclerosis develop in the vein graft distal to the valve. So it is recommended to use the valveless vein segment. However, it is difficult to locate a suitable length of a valveless vein segment to use as a conduit. We distort the vein valve by inserting 2 millimeter round-edge vessel dilator to prevent blood flow stagnation in condition of flow competition. We recognize that distortion of the valve may cause endothelial injury in the vein graft. However, we believe a gain with valve distortion is greater than losses via valve destruction. In this observational study, which included 483 patients who received vein composite grafts, propensity score matching was performed in patients who received vein grafts to match the 103 patients who received the arterial grafts. And 10-year angiography showed vein graft patients was 95% 9%, which was similar to those of arterial grafts. In this study, we used the no-touch vein without pedicle, and the valves of the saphenous vein was distorted intraoperatively. In this 10-year angiographic and long-term clinical results of our extended SAVE research trial, 224 patients were included, and 10 years later, 77 patients who received the vein composite graft were compared with 78 patients who received the right-sided composite graft. In this SAVE right trial, we used the vein as a no-touch surface vein without pesicle, and the valve of veins were also destructed. And there was no difference in overall survival and cardiac mortality-free survival between the two groups. And the patients of vein grafts was similar to those of right-sided composite grafts. In this observational study, which included 92 patients who received the vein and eye graft, 10-year freedom from vein occlusion rate was 89%, and the graft's patency was improved by greater number of distal anastomosis. In summary, patency rate of vein as a Y composite graft based on the left ITA would be comparable to that of arterial composite graft up to 10 years after surgery. Long-term clinical result of CABG using Y composite graft using saphenous vein would be similar to those of CABG using arterial composite graft. Although I didn't mention on the no-touch saphenous vein, I think properly harvested vein, Y or I composite graft may perform well in the right environment. Thank you for attention.
Thank you for that provocative study. Very interesting. I guess in the interest of time, we're still a little bit behind. We should probably just skip discussions and, well, maybe one question.
We can have one question, but then I want to invite everybody to go to the exhibit hall and visit our vendors who make our meeting possible and contemplate how they can help you in your practice. One question.
I'm Dr. Chen from Wuhan, China. I'm interested in arterial grafting. Chinese population is a small BMI than the people in the West world. So I developed a single arterial grafting and the Y grafting. I love to the sequential. So my question is, so the panel have any data show the compare the sequential Y grafting and a single arterial grafting? Any difference in the midterm follow-up data?
There are mixed data on that question, whether sequential grafting improves or decreases patency. I think the bulk of the data would suggest that more outflows, in other words, more sequential grafts, leads to greater patency. Not every study has demonstrated that.
So I think I would agree that there are two competing sort of priorities for sequential grafting. Number one, it increases the number of arterial grafts. Number two is the afterload or the resistance is decreased, which increases the flow, but at the same time, it's more technically demanding. Yes. So we actually looked at our results, and we compared our sequential radial artery grafts with these two competing priorities, and looked at the comparison between sequential radials and single radials, and unfortunately, we found no difference. They were both exactly the same. Mm-hmm. So the radial artery was technically more complicated, but it did not increase patency.
Thank you.
I think there are some situations where it's easier to make a baby Y graft than to make a sequence, and to get the geometry just right. And I think that actually is a somewhat more forgiving way of doing two grafts with one radial artery than to do a sequence, which, especially if it has an S turn, that's hard to get it perfect. But making the baby Y and putting the two limbs of the baby Y on your two lateral wall targets, that's actually pretty easy. You build the Y before you do any of the distals. Okay, let's visit the exhibits. Thank you all.
Thank you.